Welcome everybody to the Introduction to POLST in Arizona. My name is Lori Weber and I'm with the Arizona Hospital and Healthcare Association. Today our goal is to equip you with the knowledge and resources to begin using POLST in Arizona. This is a high-level webinar that we're doing today, and our target audience are healthcare providers and others who help seniors or the chronically ill make sure that their wishes are known. The POLST program mission is to improve the lives of people with serious illness by eliciting, documenting, and honoring patient treatment preferences. And POLST is another tool that we use to make sure that those wishes are honored. The goals today are to describe what the POLST is, both at the state and national level, why we would want to use a POLST. It is voluntary. We want to define the population for POLST and who completes a POLST in Arizona. We want to know when to begin the conversation around utilization of a POLST. And then we want to describe the process for having the conversation, completing, reviewing, updating the POLST, and finally submitting it to the Arizona Registry. So let's begin. What is a POLST? It's a process designed to improve patient care by creating a system using a portable medical order. So the POLST is a tool that we use in addition to advanced directives and goals of care conversations. What we're doing is actually turning the patient's wishes for care into a valid medical order that can be used by healthcare professionals. It starts with a conversation. What are the values, beliefs, goals of care? And so this is what we call informed consent. And we want to make sure that a patient's preferences for medical treatment occur when the prognosis is appropriate. So we'll talk about that. And of course, as always, utilization of a POLST is voluntary. So in Arizona, the POLST started with grassroots efforts in 2015. Arizona is part of the national POLST paradigm, and we were endorsed in 2020. It's a national movement, and the hopes are to standardize the POLST. As we know, across the country, California has their own version of POLST, clear across the United States to New York, and they enjoy having their POLST. However, with people moving across the country or traveling, standardizing the POLST is an advantage so that all healthcare professionals across the United States can honor the wishes in the POLST and feel confident in doing so. So why a POLST? We do have advanced directives that we utilize to state what kind of preferences we want for our care. We can actually fill those out at home at the kitchen table. You can do that when you're 18 years of age. It is very beneficial for designating when you need a healthcare proxy or someone to speak for you when you can't speak for yourself. As disease progresses or people get older, serious illness starts to be an issue for patients. This is where we decrease the utilization of an advanced directive because the choices have been broad. When there is a prognosis of 1 to 2 years to end of life due to chronic illness or a medical condition, this is when a POLST is appropriate. There are some gaps with advanced care directives. They can be vague and open to interpretation. Sometimes families cannot find the advanced directive when a loved one needs to have life-sustaining measures. Oftentimes, healthcare professionals are uncomfortable following an advanced directive because the selections are vague and the family members sometimes don't agree with one another. POLST protects people with their desire to have life-sustaining measures or if they do not want to have life-sustaining measures. And it's put into a medical order that's helpful for healthcare professionals to feel confident they are providing the type of care that the patient really wants. We are getting better about having conversations with patients and families who are facing the worst, serious illness, chronic disease. We're not focusing so much on testing and procedures like we used to, and we try to avoid when decisions are made under stress for both the patient and the family. Arizona actually surveyed their physicians in Arizona, how comfortable they were with having end-of-life discussions, how comfortable they were with supporting the POLST in Arizona. And it was about 66% of physicians who were in favor of putting a patient's wishes into a medical order such as the POLST, but they also wanted more education about it. And so that's why we're here today. Every state is different and has their own statutes. Arizona is no different. In fact, our pre-hospital medical care directive states very clearly that a POLST is secondary to an advance directive for patients in Arizona. So what this means is that should a patient have an advance directive and wishes also to have a POLST form, the two need to coincide and have equal choices so that there's no conflict. Should a misinterpretation of the POLST orders occur that don't align exactly with an advance directive of a patient in Arizona, then the default is always back to the advance directive. So medical providers who are validating a POLST need to make sure that they understand the patient's wishes, that they do ask if the patient or family members knows of an advance directive before the POLST is completed. Risks to update the advance directive or living will at the same time as the POLST could be a risk for patients not to get the type of treatment that they prefer, or it may be a risk of conflict for the healthcare providers. So it's important that we ask if a patient has an advance directive in Arizona when they are in favor of having a POLST as well. So who is the POLST for? We talked a little bit about that 1 to 2 year prognosis. These are patients that are usually at higher risk of a life-threatening medical event. We know that in hospice, that 6-month prognosis is what patients are deemed qualified for end-of-life care. And a lot of times, just that guess of a medical provider who's familiar with the patient, that 6-month prognosis is pretty close to the actual date of death for patients. Same is true with the 1 to 2 year prognosis, which makes it a POLST appropriate for that patient. There are many types of prognostication tools that we use, that medical providers can use, but that best guess if a patient should be declining in their medical condition or they get a new diagnosis, that's a good idea to maybe look at having that goals of care discussion and filling out the POLST. So who can complete a POLST? So we mentioned before, informed consent about a patient prognosis, the risks and benefits of certain life-sustaining treatments need to be weighed. The patient or family need to understand what the risks and benefits are. So in Arizona, a physician, MD or DO, a PA, physician associate or physician assistant, and a nurse practitioner all are licensed providers who can have that goals of care conversation and complete and validate by signing a POLST form. We do know that there are other people that help fill out a POLST or mention a POLST. Many times nurses, social workers, even spiritual care providers in skilled nursing facilities or hospices can initiate a POLST conversation. There is a place on the back of a POLST form to actually write in that person who follows up with the POLST. But in order to validate the POLST, the signature of the patient or the patient's family member or the medical provider and the medical provider are what are needed to validate a POLST as a medical order. Now let's talk a little bit about POLST screening questions, and this should help you know if it is time to have that discussion about a POLST. Number one, is the patient or family bringing up having a POLST? Remember, it is voluntary, right? And so if a patient is curious or family is curious about putting a patient's wishes for medical care into a medical order, and it is within that 1 to 2 prognosis, that's a good time to start having the conversation. Does the person have more than one chronic condition, or is the illness starting to progress to a poor prognosis? What about patient functionality? Are they frail? Are they losing weight? Are they needing more care? Do they have a lot of readmissions to the hospital? And is the person living maybe in a skilled nursing facility or long-term care facility to where having the patient's wishes in that conversation put into a medical order would be advantageous? So we talk about the surprise question, as I mentioned, about hospice care. Would I be surprised if the patient were not alive in 1 to 2 years from now? And if a medical provider or social worker or nurse knows the patient well, that is a pretty good indication of that 1 to 2 prognosis, 2-year prognosis. So we want to talk about the right conversation at the right time. It is a difficult conversation to have. There are other programs to help you refresh on having serious illness conversation with patients and families. Remember, again, advance directives can be filled out by family members at a kitchen table. Oftentimes, lawyers who are helping people fill out information for retirement will include advance directives. Remember, again, the POLST is a medical order, so there needs to be a 1 to 2 year prognosis and informed consent provided by a licensed medical provider to validate that POLST. Remember, the POLST is a process. It is on a form and entered into an electronic health record, but it is a process. And so as prognosis changes for patients, sometimes patients become well or a new medication is working that might extend their life and their prognosis is no longer 1 to 2 years. You want to revisit the need of the POLST form or change some of the parameters that were chosen. You also want to verify treatment choices should patients' lives change. Many times a patient who has lost a spouse or partner or has married will have definite change of values, and they want to maybe look at their POLST and advance directive choices again. So remember, POLST are changeable and need to be updated, especially when there's dramatic changes in patient values or in the prognosis as well. So let's talk about the elements of POLST. It's not just about DNR orders. So let's discuss the elements of the POLST, right? It isn't just about DNRs. There is a section called cardiopulmonary resuscitation. There's another section called initial treatment orders. Section C is additional orders or instructions that you can actually write in. And Section D deals with medically assisted nutrition. So when you look at the POLST form on an electronic health record or a computer, it's a white form, but it gets printed off to take home for the patient and on a bright pink piece of paper, which we'll see. So I mentioned on the back of the POLST form, there are areas for people who are not licensed medical providers, such as social workers and chaplains, to actually put their name that they help the patient or family discuss POLST elements. So let's look at having a POLST form, Section A. So this does correspond to cardiopulmonary resuscitation, CPR orders. There is a box to check, yes, attempt resuscitation. Patients and families need to understand that when they check this box, they are to expect all the additional treatments that would give the best outcome for attempting the CPR. This would include mechanical ventilation, defibrillation, cardioversion, a stay in the ICU. The other choice is no CPR, do not attempt resuscitation. So with the POLST form, in section A, if a patient actually chooses yes CPR, then in section B, we also want that patient to understand that full treatments would need to be selected in section B. Survival data with CPR changes with the prognosis and the level of health of an individual. Obviously, the older, more comorbidities and frail the patient is, the less of a good outcome with even the best CPR occurs. So that's why this informed consent by a licensed medical provider needs to discuss what the benefits and risks would be of choosing yes CPR in section A. So I'd like you to know that there are studies where it's actually 50-50% of the time that patients do select yes, they want CPR attempted with a POLST, and 50% of the time they choose no, do not attempt CPR. And remember, of course, CPR is only initiated if there is cessation of a heartbeat or breathing. So patients need to understand that, and family members. So now we're moving on to the slide with initial treatment orders, section B. Again, should a patient or family select yes, attempt CPR, then in section B for the POLST, we would ask that full treatments are selected here. The goal here is to sustain life for a good medical outcome. If a patient and family choose no, if heart and lungs stop, do not attempt CPR, then on section B, a patient could actually select any one of the three measures in the section B initial treatment orders. There would be full treatment, which we discussed, which would be a stay in the ICU using all modalities to sustain life. An example of this was during the COVID pandemic. So when patients were starting to lose the ability to breathe with CPR, they got closer and closer to actually having their heart and lungs stop. They could have opted to have a choice in the POLST of do not attempt CPR if my heart and lungs do actually stop, and they could actually have full treatment selected in initial treatment orders B, because as a patient gets close to having a situation to where they would need CPR, they could avoid it by having full treatment, which is a stay in the ICU on mechanical ventilation. That's one component or example we learned from COVID. Again, select treatments is another option with B. And here we're attempting to restore function, but avoiding intensive care or resuscitation. Examples of this would be using antibiotics, maybe IV fluids, but they could also have that selection of do not attempt CPR. And then, of course, in selection, part of selection treatment orders is comfort-focused treatments, right? So this maximizes comfort through symptom management, but allowing a natural death should a patient select do not attempt CPR in section B. I do want to point out that it is important to tell patients that if they select comfort-focused treatments, that they will be receiving aggressive treatment for symptomatic problems or issues, such as pain or difficulty breathing, even though they do select do not attempt CPR. It's important for patients to understand that there's no abandonment of a patient who chooses not to have life-sustaining measures on the POLST form. Moving on to Section C, additional orders and instructions. For patients who choose comfort measures, many will actually write in a hospice of their choice on Section C. Others maybe would like to write in orders such as time trials for perhaps ICU stays or mechanical ventilation. They can put in time trials here as well. Moving on to Section D, medically assisted nutrition. So this is an important conversation to have for patients who have advanced dementia and also who have a high risk for stroke. Medically assisted nutrition is via a surgical placed tube or an NG tube to actually provide nourishment through those artificial means. Sometimes patients and families will misunderstand how much medically or artificial nutrition can help a patient. It depends on the prognosis. So there again, having informed consent about the risks and benefits even of medically assisted nutrition is an important conversation to have. Many times they will have trial periods and we have a selection for that. Selecting no artificial means of nutrition desired is a component of this, but we're talking only about artificial nutrition. And then there's also a selection that this item was discussed, but no decision was made, and standard of care is provided. And in the state of Arizona, standard of care, when a patient chooses no artificial nutrition, remember that's with a surgically placed tube or an NG tube, that does not rule out hand-assisted feeding in the state of Arizona. So in terms of dementia, advanced dementia, or stroke, and patients or family do not want to be hand-assisted fed, they need to write that out. That could be written out in Section C or in an advance directive. Otherwise, the standard of care stands in Arizona. If they are in a care facility, there will be an attempt for personnel to feed the patient by hand. Then signatures. So it's important now that the patient or family representative, the surrogate, understands all the selections made on the POLST. And they need to sign the POLST first before the medical provider, which denotes that they do understand the risks and benefits of all the life-sustaining treatment or treatments they are foregoing on the POLST. Then when the licensed medical provider signs the POLST, they are attesting to the fact that yes, the patient does understand or the family does understand the risks and benefits of the treatment choices or the treatments that have been foregone, and the signature validates the POLST as a standing medical order. So let's talk about completing the POLST form again. Remember, a healthcare provider is necessary in order to make sure that the patient and family get the informed consent and can sign the POLST form to validate it as an order. We want to make sure that the patient's decisions are reviewed and affirmed and that the patient signs the form as well. Next is what to do with the POLST form, right? Just like an advance directive or goals of care conversation, the POLST needs to be recorded in the electronic health record and communicated to people who care for the patient. This is the surrogate or family members need to understand that a POLST form has been completed, documented, and uploaded into the electronic health record. Next, it's time to print off the POLST form onto a bright pink piece of paper. In Arizona, we also have the pre-hospital DNR on an orange form. Both of those, as long as they correspond with the same treatment choices, can be housed at a patient's residence. And that it doesn't matter where they reside, whether it's in a skilled nursing facility, assisted living facility, or at home. The bright pink piece of paper will alert the EMS system if they are called to a patient's place of residence so that they can find the POLST form and verify the patient orders. A lot of times it's placed with the orange pre-hospital DNR. And as long as the selections are the same, they can have both of them. And they either put them on the refrigerator, back of the front door, or at the foot of the bed where the patient's sleeping. Remember that we want to share a copy with the surrogate family members that need to be aware that the patient does have a POLST form, and also medical providers. So once a patient does have the pink POLST form at their residence, we want to also make sure that providers are also alerted that the POLST form is available in the electronic health record. And this comes to the advantage of now having a registry in Arizona. It's the Arizona Healthcare Directive Registry. Unique to Arizona also is that the POLST form needs to be attached electronically to an advance directive or living will in Arizona. And we'll talk a little bit more about registration of the POLST form. Next slide talks about registering the POLST, and there are websites that you can go to. They're housed in Contexture. It's Arizona's Health Information Exchange, and you can go to the website there to register as a medical provider to upload POLST forms with advance directives in Arizona. If a patient does not have an advance directive, currently the POLST cannot be registered in the Arizona directory. It doesn't mean that the POLST is invalid. In fact, as long as a patient has the POLST form at their place of residence, it will be transported along with the patient to the hospital or emergency facility and should be honored as the patient wishes. So reviewing and updating the POLST. Remember, this is a process. Values and also treatment preferences change with time with the patient. So when should you have that conversation? For healthcare professionals and also primary care providers, during appointments, right, when you're following up with the patient, especially if there's a change in level of care. Also, has a patient moved from home to a skilled nursing facility? The POLST is portable and can actually go with the patient without having to change the POLST form unless the patient has changes in treatment preferences or values in the patient's life has prompted them to want to reevaluate their choices on the POLST form. Next is considerations for implementation. So part of the Arizona Hospital and Healthcare Association is to meet with all kinds of medical providers across the state. Thank you for your care of patients facing a prognosis of 1 to 2 years and understanding and offering information about the POLST form. Remember that the POLST form is always voluntary, it's portable, can follow the patient wherever they reside or get medical treatment and care, and it's good across the whole care continuum. In summary, the patient or surrogate decision maker agrees to have a POLST form. There needs to be discussion about the diagnosis and prognosis. What's appropriate for a POLST is that 1 to 2 year prognosis. It's shared decision making with a licensed medical provider who can provide informed consent, meaning talk about the risks and benefits of treatments that are offered to patients who need life-sustaining treatment. The POLST form gets completed, it gets uploaded in an electronic healthcare record. It also needs to be documented, just as any medical visit with a patient that you discussed and filled out a POLST form. And then it needs copied off on the bright pink piece of paper for the patient to take home or where they reside. Remember to also remind patients to talk to family members and alert them that they have a POLST form. Their medical provider, primary care provider, should be notified that they have a POLST form, and it is an electronic health record. Remember that the POLST form is not a healthcare directive, it's a valid medical order that needs to reflect the choices in an advance directive, especially in the state of Arizona. If the advanced directive is not updated along with the POLST so that they have the same selections, then the default in Arizona is back to the advanced directive and the POLST is deemed invalid. Next is resources that I'll share with you on the PowerPoint for more information. The ArizonaPolst.org. There's also the National POLST. If you'd like more information about the standardization and increased educational opportunities for you, especially with serious illness conversation and others, including the registration of the POLST form in Arizona. Thank you.